Good evening, everyone. Good evening. Thank you so much for joining the session. I know it's a little noisy, but really, thank you so much for joining our last session. I hope you guys are not too tired from the long day at the union. So today, we have a really interesting session that I feel is a good segment from the last session where we heard from communities on the TB stigma. And what we are trying to do from the Global Fund and also with the technical partners like Stop TB Partnership and also our civil society and community partners is really understand to what extent TB stigma is impacting access to TB services. We have very exciting guests and presentations. My name is Hae-Young Lim. I'm a human rights advisor at the Global Fund. So let me introduce each of the guest speakers now, and then please continue with the presentations. And we hope to leave as much time as possible for the Q&A. So if I have to, in a way, rush you through the presentation, my apologies. So first of all, I'm so glad that Dr. Emperor was able to join, because it is not often that we hear from NTP on how TB stigma is important and really committed NTP colleagues to work with the civil society and communities to tackle the TB stigma. But Nigeria has been really in the front line in trying to identify TB stigma and identify also activities that needs to be addressed to remove TB stigma. So Dr. Ampro is a director of the Global Fund TB program at the Nigeria, the TB and leprosy control program. And without further ado, I'll give a floor to Dr. Ampro for presentation on Nigeria TB stigma assessments. Thank you.
Hello? Okay, so good evening all. Like you said, my name is Dr. Emperor. I'm going to talk about the outcome and lessons learned from our TB stigma assessment in Nigeria. You are aware how the impact of TB has been globally, and Nigeria is one of the is number one in terms of burden of TB in Africa, and also among the 9 high burden countries. TB has been affected by stigma, however, is less spoken by national programs globally, and the evaluation and impact of TB along the TB service cascade was done by Nigeria to ensure how we can actually understand this impact. Just like a brief profile, we know, like I said, we assist, but over the past 5 years, Nigeria have done much, and the case finding have actually increased so rapidly. You can see from the graph there, from almost 90%, 90,000, we are hitting 285,000 cases per annum. And this year, we hope to hit more than 300,000 cases in Nigeria. And based on that, our idea is that even though we are hitting these numbers, there is still a huge gap. So our approach in the next few years is to see how we can address TB challenges holistically. And one of those areas we need to address it is looking at those things that have impact access to TB care. And that's one of the reasons we did this cascade assessment for Nigeria. And we did it in 18 states, and we did in three local governments per state. The states were determined by us, and we engaged a consultant who were actually who did this assessment. We did a total of 250 people per state, and then we interviewed 4,500 across the 18 states. People who were part of those were TB patients, those members of their family, community, and also healthcare workers. Stigma along the TB was developed using a respondent who reported yes for any issue that has to do with diagnosis, initiation on treatment, or remaining into care. Data was analyzed, and then we came up with these issue results. Out of the total number of 3,252 TB patients who were interviewed in the 18 states, 59% of them were men, and also 50 were between the age of 25 to 44 years. So they're actually active age period. And then the majority of the respondents, about 75% of them that within the survey are actually TB patients already receiving, who are on treatment at that point in time, and the rest were actually those patients who were not receiving any treatment. So about a two-thirds of them, which about 65% of the surveyed patients, has completed secondary school. So they are actually, in terms of education, they are not actually illiterates. Look, this may be a little bit tiny, but it was actually determining stigma in the following areas, looking at those who choose carefully who they tell about TB. You can find out that people are actually not comfortable telling people about this TB disease. Also, keep distance from others to avoid spreading the TB germs. And also, those who are afraid to tell those outside their family that they have TB are actually some of the areas that were assessed. Those who also feel alone, that because they have TB, they feel very lonely because maybe family members or other people outside do not care about their disease state. Some that feel hurt and some that feel guilty that they are bringing burden and disease to their family were also assessed. Those who have to lose their friends because they have TB disease was also among them. Those who are afraid they have HIV, worried about having HIV, those who were afraid that their family may have TB are also among them. So these were assessed, and what we found out in overall result is that 2/5 of the TB patients reported they experience stigma. So even though we don't talk it as national program, it's in existence. So the best way we can do is to start discussing how to address stigma among our society. So about 53% actually suffer stigma in the community. There's also high level of stigma of TB patients among those who want to disclose their cases. So mainly they disclose about 80% face stigma, and then those who feel alone are about 50%, while those who feel they are hurting their family is about 50%. By the place of residence, stigma was slightly higher among the urban slums than the rural areas. So which is actually maybe because of maybe social awareness about the disease. The impact of stigma on TB cascade was so much that you see that those who it affects care, access to care, recognizing the symptoms was almost 63%. Those who are getting accurate diagnosis were about 43%. Those who feel that who want to start treatment was like 40%, and those getting treatment adherence was like 39%. In all, what we felt was that even those, it also affects even the completion of their treatment because they don't have support. And then those who get post-treatment follow-up are actually at 5%. In conclusion, yes, we know that we keep not discussing, we leave TB as a diagnostic issue alone, but there is social component that is really associated with TB. And based on that, there is real high and passive stigma across multi-settings. TB stigma has direct negative impact on the whole TB cascade. And also, if you check it critically, you can see that negative and psychological social impact and thus evidence-based strategies need to be multi-sectorial. There is also need to have a huge investment in TB to bridge this gap that may be noticed. I just want to say thank you to all our partners, WHO, USAID, and especially Global Fund that supported this assessment for the country. One thing that is key is that there is need for in-country knowledge about stigma and how to address stigma among the national programs. Thank you so much.
Dr. Emperor, thank you so much for your presentation. I'm really actually surprised by high level of self-stigma and also the stigma at the community level. And I'm sure there will be a lot of questions, but maybe if I already bank my question for you, would really love to hear later on the NTP's role in addressing TB stigma and how Nigerian NTP can set the lessons for other countries to follow. Our second presentation is from Dr. Ahmed and the experience in Bangladesh on implementing TB stigma assessments. And I see that Stop TB Partnership, the colleague is here. Great, many thanks to Stop TB Partnership who has really generously supported us mobilizing TB stigma experts to work with the country partners. And I believe that this study is particularly important and interesting because I know our colleagues have really tried to integrate the gender aspects as well. So really, Dr. Ahmed, floor is yours.
Thank you, Heyung. Good evening, ladies and gentlemen. This will be quite a contrast from my previous presenter, Dr. Emperor, because he has presented results. And I think it's good in a way because we have just initiated our study. We'll not be sharing results, but we'll focus more on how we are approaching this study. First of all, I have no conflict of interest to declare. As many of you may know, Bangladesh is still, again, a high TB burden country. And we did not have a chance to update this slide with the Global TB Report 2023 because it was published later. But the estimated number of cases gone up this year, 379,000 from 375 last year. Mortality reduced from 43 to 42,000. But unfortunately, the treatment coverage that we had 81% treatment coverage in 2021, but in 2022, it's 69%. So we are kind of walking backwards. As you have already heard, I think the previous session was also highlighted the importance of stigma and where it is related with the TB care cascade. And we have seen that stigma is associated with almost every step in the TB care cascade. It results in delayed care seeking, delayed diagnosis, treatment interruptions, and very often unfavorable outcomes as well. And as Heyung was saying, gender-based violence. In many of our countries and societies, power imbalance exists, whether we like it or not. And very often that power imbalance across gender results in gender-based violence. And our women face a more steep challenge especially when they're sick. So we will be looking at the gender-based violence aspect of this as well and its relationship with stigma. This is our conceptual framework. We know, we have seen already, stigma exists in individual, in families, in communities, and also among the healthcare workers. And the external stigma all culminates into the stigma of an individual, of a person living or diagnosed with TB, and disrupts in the entire TB care cascade. Our objective is to assess the level of stigma in people with TB, their family members, the healthcare workers, and also the entire community. With a focus, as we have already mentioned, on gender-based violence among the TB-affected people. What are the tools that we are using? As Heyung already mentioned, the Stop TB partnership has been instrumental in developing a data collection instrument. We have adapted our questionnaire from that instrument. And for violence against women, we are relying on Bangladesh Bureau of Statistics. They have done a survey. We have adapted from their questionnaire and being informed by that report as well. We have both quantitative and qualitative exploration. I'll not go into the detail, but for the quantitative part, we'll be interviewing more than 1,000 participants. And for the qualitative exploration, we will be conducting nearly 50 different interviews. These are our participants. Of course, we will be only involving people who agree to provide informed written consent, are adults from all these different groups. So I personally have been involved with TB research for more than 12 years now. And we have my supervisor here, she is doing it for more than 25 years. But this is still a different challenge for all of us because we have never done a stigma assessment. And we know that this is very sensitive. So this has been a different experience for all of us, and we have tried to be very careful. The questionnaire or the assessment tool has been extensively discussed by the Community Rights and Gender Working Group members at the NTP. And we have validated the questionnaires with the stakeholders and also by field testing. And recruitment was also different for this particular project. As we tried to recruit, we have been able to recruit 50% of the team members from TB survivors. and the team is also gender balanced. We have provided them with intensive training so that they can ask these sensitive questions. We have done only a quarter of our interviews so far, and more often than not in the past, we have seen preliminary results often mislead us, so we'll not divulge into any results. But we can share some of the quotes. As I was, before coming here, I was in a pediatric TB presentation where someone was saying that in many cases, people don't, in case of children as well, people don't want to accept that they have a TB infection. And this came up in one of the interviews as well. And in the second quote, you'll see that a participant was complaining about the changed behavior of the closest family members. So this is very much existent, and we look forward to present our findings maybe next year. We are doing this with the support from the Global Fund, and we are a subrecipient of the National Tuberculosis Control Program. Thank you very much.
Thank you, Dr. Ahmed. We were really excited to partner with the ICDDRB on this project, knowing your, the research credentials, the organizations you yourself have. I know there will be questions, but just my another question to maybe the bank with you at the moment is that earlier we have understood that gender responsive and gender transformative TB response is critical in addressing TB. And we have understood that there's a man who is more affected by TB, but then there are different barriers and stigma, how it affects men and women differently. And my question to you later on would be how these kind of assessments can be tailored to really dig into more of the gender specific, the impact of the TB stigma or the different barriers that the different communities are facing in order for us to design more gender responsive the programming. I'm putting you on a spot, but knowing that you're a TB expert. Great. Our third presentation is from Jerry. Jerry is the Executive Director of TB Voices Network in Ghana. And I have been working with Jerry for a long time on the community rights and gender programming in Ghana. TB Voices Network have been really instrumental and pioneering in many of those human rights programs in the TB context Ghana. Jerry, I'm so excited to have you, and floor is yours.
Right, so good evening, and then welcome to this section. So my name is Jerry, as I said, and then basically we're going to look at the areas in terms of stigma assessment that was done. We look at the results and the lessons and some key takeaways. So I declare I have no conflict of interest here. Right, so this is going to be the outline of my presentation. We look at the introduction. We're going to look at the objective of the study, the method that was used, and the key findings, recommendation, and some takeaway. So this study was done in 2020. This was the first ever TB stigma index study that was done in Ghana. So we basically used the baseline of 2018. That was the report from the WHO. That was what we used for the base. So that's why you see 2018 there. And we also look at the benchmark of the Stop TB partnership, reaching 90% people with TB, and also putting them on treatment, reaching 90% of key population, and also achieving 90% treatment success by the end of 2020. So TB-related stigma discourage TB patients from seeking healthcare services, and also at the forefront of low TB case detection, and then poor quality of life of TB clients. That was what my previous speakers spoke about. And then the true extent of TB-related stigma as a cross-cutting barrier to accessing quality and affordable and timely TB care and support services in Ghana is not well understood. So that's why the study was done. So the objective of the study was to assess the level and the dimension of TB stigma and gender differences among people diagnosed with TB in Ghana, and also to assess the level and dimension of secondary TB stigma observed by family members, caregivers, or people diagnosed with TB also in Ghana. And the third objective was to assess the level of perceived TB stigma against people diagnosed with TB in community and stigma observed in the community in Ghana. The fourth one was to assess the level and dimension of perceived TB stigma against people diagnosed with TB at the healthcare settings, and also to look at the extent to which the policies that exist in terms of stigma in Ghana. So we look at the study area. We conducted in 8 administrative regions of Ghana. That is in the Ghana have 16 regions, but we did it in 8 out of the 16 regions. And the study design was cross-sectional study design with mixed method approach that was also employed. The assembly size was a total of 1,250 persons living with TB, persons who have TB, and 975 family members that are caregivers, and then 1,960 community leaders, that's opinion leaders, and 295 healthcare workers that were interviewed and recorded. The sampling technique was also used, and also we got ethical approval from the Ghana Health Service to conduct this particular study. So these are the key findings. So stigma experienced by persons with TB and persons who have TB. We realize the chart there, about 8.7% female said that they experienced stigma in the study, and also 13.3 male also say they experienced stigma, and transgender was 0.3%, and those who did not they didn't experience any stigma was 77.8. This tells you that as the study, the chair of the session said that men are more prone to TB than female. They show that we need to take a critical look at the approach and design programs that would tailor into finding more missing people with TB in Miri. So this was also in terms of experience by family members, that's caregivers that were interviewed. 6.3% that were female also said they have experienced stigma within the family settings, and also 3.3% of male also said they've experienced stigma taking care of their persons with TB and persons who have had TB also. So this is in the community study in terms of the TB. We asked the question, how many people with or who have had TB in your community do you know personally? And some of them said about 31.1% said none. Only one, 27.3. 2 or more said 21.3. And then do not know also 20.3. And have you seen or heard a member in your community who had TB being diagnosed because of his or TB status? So this was a question that I was going to ask, and then the sample was 1,966, and then the respondent to it was no was 72%, and yes was 27.1%. So stigma experienced by healthcare workers. This was the result. It tells you clearly about 32.9% experience stigma. Even if it's 3%, it tells you how important it is that we need to address issues with stigma within healthcare workers in our settings. So what are the lessons learned? Stigma remains a critical issue in the control of TB in Ghana and impeding access to and provision of TB services. And then persons with TB family members, caregivers, and healthcare workers reported being stigmatized and knowing others who have also experienced stigma before. And the stigma was also exhibited in the community across all categories of the TB journey study. Stigma also inhibits family from providing the support to family members with TB or who have had TB. The result also suggested that the existence and enforcement and then low media coverage of laws and policies that protect persons with TB at both the subnational and the national level do not really, it's not encouraging enough. And TB stigma mostly took the form of gossip, as Doc said, and also avoidance and isolations of persons with TB and persons who have TB in the community. Policymakers confirm the existence of laws that protect the rights of persons with TB at the national level, but it is not being enforced. However, those laws are unenforced at the subnational level to even be able to, including subnational media coverage. So policy that protect persons with TB at the subnational level need to be also looked at and be enforced at that level. Recommendation: reducing step stigma by empowering individuals to believe they can alleviate their health condition and also circumvent further negative consequences that inhibit them from seeking and accessing healthcare in Ghana. We need also looking at organizing stigma reduction programs in the communities and engaging opinion leaders, especially opinion leaders, by raising awareness and regarding the negative health consequences of being stigmatizing persons with TB and its effects on the healthcare and provision. We also have to look at organizing routine stigma reduction training for healthcare workers. It is very important. And in the current grant, we have done something on this with the PR, where we have targeted healthcare facilities, where we are training healthcare professionals on how to destigmatize against TB clients, especially to reduce stigma. And some of them are ambassadors within the healthcare services where they produce their, give their services to individuals. We also look at enacting and enforcing specific laws and policies that look like addressing and protecting the fundamental human rights and individual affected by stigma in the society. Thank you very much. And these are our partners: the Stop TB Partnership, Geneva UNOPS, Webcast Global Fund, and the Ghana Health Service. Thank you very much.
Thank you, Jerry, for that really interesting presentation. It's really interesting that you also looked at the TB stigma among the healthcare workers, and you have mentioned the TB stigma reduction activities for the healthcare workers is also important. But I'd like to hear, what are some of the activities that donors and partners may be able to, and NTPs may be able to support in rolling it out in order to really tackle the lack of implementation of the existing the laws to protect the TB communities, and also the different aspects of addressing TB stigma. Well, that's my question banking to you, but I'm sure there will be other questions from the audience. So let me invite the audience before I ask my questions for answers for my questions. Any questions from the audience yet? Please.
Thank you for the very great presentation. To my brother from Ghana, okay, it's surprising to see that the stigma among male, the male face more stigma than the female. Uh, it would have been good to see the report, but is there any reason for this? And it seems you show the stigma in the family. You didn't show the stigma in the facility for male and female. So I think the male face more stigma at the facility, right? So it will be good to see what kind of stigma, what kind of stigma is this, so that you are targeting and then you are addressing it. That's my first question. My second question is there any variations from region to region, from district to district? Are there districts where the stigma is low, where the stigma is high? Are there in-country variations when you talk about stigma that is faced by TB patients? Thank you.
Right. So thank you very much for the question. And very interesting to know that, um, men faces more stigma because of their masculinity as men. A if a man, for instance, have TB, the man, first of all, self-stigma is important. He will not, he doesn't want to disclose it because one, he's basically the breadwinner of the family, okay? And then if such person is stigmatized, you know the consequences that goes with it in terms of taking care of the family. This is a person that needs to go out and earns and come and feed the family in our settings in Africa here. And so they faces more stigma because once they are diagnosed with TB and other people get to know it, they shun from even trying as much as possible to mingle with people because they feel like the masculinity in them as men has reduced and therefore they need to move away and isolate themselves from the general population as well. You didn't see the other data studies because it's more of a presentation. I didn't want to put a lot of data, but you look, we did in 8 regions, and basically the results shows that each of the 8 regions, tells you which of the stigma is high among them. But it tells you that in each of it region, there is stigma in all the 4 categories, including in the community, at the health facility, and also the caregivers, and then the person with TB. So it cuts across. So if there's an intervention, probably there's the report will show where we need to target more on which of the stigma that we have to work on as well. I don't know if I can answer your question on the issue. Okay, so what we are doing is also train, the PR has trained some health facilities. So I've trained about 20 health facilities on stigma reduction at the various health facilities. And this cut across all the divisions of the health services at the facility. So we are not only looking even at only the TB aspect of it, but we bring people from different aspects of the health services, the providing services at different levels together, and then train them on how we can reduce the stigma associated within the health facility. And this time, we have appointed ambassadors. So each of the facility has a TB ambassador, TB stigma ambassador reduction person. So he or like a focal person in the health facility to make sure that stigma in the health facility is reduced. What the program can do is because it's more of a pilot, can also look at how best they can support to scale up the intervention to cover all the other health facilities that we have in Ghana to be also to reduce stigma in Ghana. Thank you.
Thank you, Jerry, for the great response. Do we have another hand?
Good evening. Thank you for your presentations. I'm Riley from Heidelberg University. We are talking about stigma here, and we are concluding that we need to find ways to combat it and how to address it. But looking at the numbers, for example, I remember Ghana's numbers, something like 22% experienced stigma, which means that 77 did not experience stigma. So when we think about kind of crafting the programs to implement or the interventions to implement combating stigma, I'm curious, did you, and from the colleagues who already have their results, did you probe into why someone felt that they didn't experience stigma and why they felt okay with their diagnosis and treatment? Because I feel like the start of crafting interventions can probably be from that majority of the TB community. Thank you.
Thank you. That's a very good question. So I want to invite Jerry to respond to the kind of first part of the question, but also Dr. Ampro on, because NTP plays a really important role in crafting the programs and crafting the message, and what would be NTP's role? Maybe that can tie up with this response.
So, thank you very much for the question. If you look at the result, even if it is even 3%, it's quite something that we have to look at. So even 27% is quite a lot for us to look at the areas that we need to work on to make sure that we have zero discrimination. We don't even want to have 1%. So having a 20% tells you that it's quite a lot that we need to work to reduce the aspect. Yes, the report will show the various questions. There's a questionnaires that is to it as to why they experience the stigma, why people will say no. Others will say I experienced stigma because of there's a questionnaire that we went through, and I didn't present the questionnaire. It's quite a lot. So the report is there. So when you find the report, you get to see the details as to where the questionnaire, so where the respondent gave the answers as to why the reason they felt they were stigmatized and they were not stigmatized against. Thank you.
Okay, thank you so much. I think basically based on our understanding of the assessment, there is a key knowledge gap and cultural beliefs that actually are holding on to people that made them to stigmatize with patients. You can hear things like don't use the same cup with this patient, don't use the same spoon, don't lie on the same, don't talk to the person, cover your mouth when you're talking to the person, not even the patient covering the mouth. So there are a lot of knowledge gap. Some say is things like witchcraft, pussycat, and all that are the causes of TB, and then it means that the person is bewitched for something. So the basic need is that to avoid being affected, you need to stay away from the person. Families do not allow you to go to those families that have TB. This time, if you look at Nigerian results, we have almost like 50% stigma among patients, and even in health facilities where you think knowledge is important, you find TB facilities being placed close to mortuaries, to morgues, where because it's set at the back of the hospital, because they feel that they don't want the other patients to interact with TB patients and all that. So that knowledge gap is key to be addressed. And to just answer back to what we are doing as program, we are working with the community programs to initiate, especially with the experience with One Impact. We are trying to use that approach to see that we integrate. It's going to be an integration approach where we do TB, HIV, and malaria issues, but at the same time to increase the knowledge of the communities as it relates to TB and what happens around TB. So if you look at the One Impact tool, it gives you that much capacity to reach down to the community, and then we're working with the various community heads of each disease entities to ensure that all the 36 states plus FCT, because that's what we have as states, will be, the implementation will be at that level, but mostly at the community level, focusing mainly on the urban slums, because if you look at our results, the gap of knowledge is more at the urban slums, and that's where the stigma is still very high. Then we're also trying to engage the legislators to look into as legislative components issues like losing jobs because they have TB. Security men lose their job. Some of them who are drivers lose their driving job because we hear these things in the past, but it didn't look so impactful. But with this assessment, you can see that it's actually there in the community, and we are actually overlooking them. And with the new grants coming in, it's been a huge focus, and we're trying to block those gaps and see how we can increase knowledge among the community to ensure we reduce stigma for TB patients, which can actually increase access to care. Thank you.
Thank you very much, Dr. Ampro and Jerry, for the remark. If I may just add, so the 30%, I was thinking the same thing, looking at the statistics. Okay, so 30% of people who with TB on treatment feeling stigmatized, and then 70% are not. So part of me thinking, okay, then we are making a really great progress. But then I believe the participants is actually the people who are accessing TB services. And 30% of people who are actually accessing TB services feeling stigmatized, then how many people are not accessing TB services because of the fear of the stigma and self-stigma and different barriers. So while your question is really thought-provoking, and how do you really make the TB response that is accessible for everyone, I think that is a kind of key discussion. And thank you so much for raising the NTP, the role of NTP. And when you said that, the TB ward are generally in the back of the clinics, etc., I kind of thought, okay, the Community Connect Center is next to the elevator in the intersection where we have no protection from the noises around us. I think we have a lot of work to do with the unions and other partners to really put the community in the center, maybe starting with a better place where we can really connect. With that, I want to give Dr. Ahmad the opportunity to respond to my very complicated question. I know you're a researcher. How do we make these tools more gender sensitive that we can really draw out the gender differences in stigma and discrimination, etc., that are affecting different communities?
Thank you. So I think you would be better suited to answer that question and not myself because, but yes, I think this is a new experience for us, and what we have seen over the years in TB programs, the funding in TB program is very much number driven. So it has always been like the country needs to report this many TB patients. This is the estimated number of cases. You have to report this many cases and you'll be given this number of million US dollars. And that has created, I think, an imbalance, an insensitivity in the programs where we are more focused on numbers and how to get them. Rather than the quality or the humanitarian aspect of the program. And this is, I think the CRG is a new addition in the Global Fund programs, in the funding requests, and it's a very welcome addition, but this is, as you just said, much like this place for Community Connect here is also not very much in the focus of the grant making decisions, and we should place more emphasis on those, and these assessments that we already have results from some countries, but of course we don't have results from all the countries, and we should have more results because, as we were seeing, there are many contrasting results. Like in Ghana, you have seen 27% people with stigma, whereas in Nigeria, if I can remember correctly, it was 66%, something like that. So yes, there are very contrasting results. And also we are doing them mostly on people with TB and their family members. But as you rightly said, what about the people who are not entering the system due to this stigma? What are we really doing to reach out to them? I think this is, again, thought-provoking. I don't have the answers yet, but I think more these assessments are done and we have more data, then we will be able to give a closer look at the issue. And also we need a lot of advocacy to put that really in the spotlight and maybe reduce the importance on these numbers that we are trying to get into the program. Thank you.
Thank you, Dr. Ahmed. I disagree with you. I think you really answered my question, really spot on. Putting the human faces in the numbers, it's not 4 million missing TB cases, but there are 4 million people with a TB who are missed by the systems. So really, thank you so much for the intervention. I think we are right on time. I don't know if there's one last burning question. If not, I can thank my distinguished speakers and really pioneering in this area. And really, I thank you for your attention. Thank you very much.